Dobro jutro. Well, I was supposed to talk about the specifics of the technique of laparoscopic TME, but I think you had already yesterday some opportunities to see it in the live surgery, but also I think you have seen some videos yesterday. So I don't want to repeat that, and again we are moving quickly to live surgery again today, where you will see two more procedures, one TME and one abdominal perineal resection. So what I will talk now for the next 10 minutes or so is something slightly different, but it has to do with TME surgery. I would like to show you an example of how we tried to standardize the technique and to come to some sort of consensus around the world how this procedure should be done and how it should be taught. So why did we do this? So what is the problem? The problem is this. There is a theory, and then there is the reality. And often, like in this picture, the theory looks much nicer than the reality. So the theory, we all know about the theory, what has been described as the holy plane. We know where we actually should do the resection. But then doing it is slightly different. And you can see here different surgeons doing the same operation, but it looks very different in all of them. So there is a lot of variation, a lot of variability between different surgeons and different techniques. So why is it important to have somehow a common approach where you can say that we're doing the same thing? There are three main things. One is, of course, the oncologic quality. If we have a standardized technique, and we know if we are applying this technique, then we can predict what the outcome would be. And we all know that this is the type of specimen that we would like to see. So, at least theoretically, if we have a standard approach where we know if we do it or if we adhere as much as we can to this approach, we are more likely to get something like this. The second problem is this, and I think I spoke about this when I was here last time in April. The complication rate in colorectal surgery is extremely high, and I think we often ignore that. We think everything is okay because we see the patients a few days after the operation. Most of them go home, and then we may see them again in follow-up. Maybe we don't see them again. But if you actually analyze what is happening to them over the course of years, not just days or weeks, you would find that up to 70% of these patients suffer of some sort of complication. Part of that, again, I think is surgical variability. And if you have, again, a standard procedure that we all apply, then we can be able to predict the outcomes in terms of complications as well. And then the final thing, I'm not going in there again because you have heard a lot about learning curves now, but you know that this learning curve is very high. And again, I think the learning curve can be shortened by having a standard approach. If we all know what we are doing, if we are all on the same level in terms of how to perform this procedure, then I think we can shorten the learning curve. Trainees often get confused by seeing different things in their training. Seeing different things is a good thing when you're experienced and you want to broaden your horizon. But I think trainees are often confused when they see one day this procedure and the next day this procedure, so it's much easier to adhere one standard approach. So the aim was really to find a consensus, and we didn't really know whether this would work or not, because surgeons are all individuals and they have all their own mind, and they all think that their way is the best way. But anyway, we tried. So we thought that the only way of convincing people to come to a consensus is to apply some sort of scientific approach, so no one can argue with it. So, and this was the approach that we used. The first stage was that we interviewed people. These were a few people around the world who we knew that they were experts in what they were doing, and what we asked them is just to, in a typical interview approach, that we would ask them questions about how they do the procedure. And then the second stage was open up the group to a lot more surgeons and ask them through a questionnaire, which was based on the information that we had from the interviews about their techniques. And then finally, in the final stage, there was a focus group which came to the final consensus. This is all a bit abstract if I show you like this, so I'll show you an example. So this is an excerpt of one of the interviews. I think it even plays, I don't know whether you can hear this. Anyway, this is what we did. We interviewed these people and we transcribed everything word by word. And from these interviews, we could then extract the data. So each thing that they said was taken out from the interviews and then categorized. So we were looking at different categories we can put it in. So we were asking, to which task of the procedure does this information belong? And then we tried to categorize it further into what kind of information or what type of information is in there. And then finally we created these lists of data from people, what they said. So the aim was to have all these interviews broken down into their components and look at all the information and all the data that was in there. And you can see on this right side, so all this here is all about, I think it's about stapling. So this is about one step of stapling, what people said. So we had a lot of information and a lot of different information. And then we took all this information and created a question. So basically what they said, this was the kind of variation of data we got, you know, these were different answers that we got from the interviews. And we summarized this in one question. So this question again is about the staplers. So what stapler should be used for the division of the rectum? And these were the possible answers that we got. And in a similar approach, we created something around 60 or 70 questions. And then we created a questionnaire with all these different questions. It was an online questionnaire. And we identified certain people, certain key people in different regions of the world. And we asked these people to distribute the questionnaire in their area. So with this approach, we got to a wider community. And what we really wanted was not to send it to all the surgeons they know. What we wanted to send it to surgeons who they know that they are experts in their field. We had little control about that. We didn't know who these people are really, but we got some information about them. And our minimum requirement was that they had to have at least 50, an experience of 50 laparoscopic TMEs. These were the people that were helping us. You can see who was in Russia. And these people were making it all possible because they were sending it out to their colleagues. And in such a way, we got answers to all these questions. And then what we did, based on the answers that we got, certain questions needed to be adapted slightly, or we had additional information for certain questions that we were putting in. But also, we were putting all the results that we got from the first round of this questionnaire on a second questionnaire. So we were sending out the same questionnaire again to the same people, but this time we were putting the results from the previous round on the questionnaire. And the reason for that is that people could reflect on what they were saying before. So, for example, if one person was saying, I'm always using 60 millimeters, and they got the answers back from before, and they realized that 95% of their colleagues were saying 45 millimeters. They could think about it and say, maybe I was wrong, or maybe I was right, and they reinforce it. So we sent it out to the same people again, and you can see these people, they had a lot of experience. And by doing this, what we are trying to achieve is to increase the level of consensus, because people start reflecting and thinking about what they've done before. And this is what data that we got from the second round. What you can see, this is basically a scale of agreement. So 100% means that everybody agreed. And you can see this is the first round, and this is the second round. And these dots, these are different questions that we asked. And you can see that the general trend was that with the second round, the agreement went up. So we increased consensus. So after that, we then had this focus group meeting where we discussed with about 20 or 25 surgeons from around the world again all these details. And we were clarifying what are the answers from all these questions. And based on that, we could finally create a text, a document, which describes in high detail each step of the operation and how to do each step. And it's not just a description in terms of what I've shown you before, you know, which stapler to use or which instrument to use. It is more about what are the crucial landmarks that you need to see. How do you expose the tissue? How do you use your assistance? And we do this for each step in high detail. Whether this is now the right or wrong way, I don't know. This is just the agreed way. And it doesn't mean that this is the only way of doing this operation. But what we hope is that by putting this on paper, that we have at least something that we can compare to. And maybe one of you will come up tomorrow and say, I have much better operation. And then of course we can change things. But this was for us a new thing to do. So we tried something that hasn't been done before, and we hope that this is a model for other operations and other specialties as well, to create something similar. Some people say this, they say in theory your enjoyment is increasing with the more planning you do, but in reality the more you plan, the less you can enjoy things. And maybe this is true. So I certainly don't want to take away the enjoyment of surgery, but I hope that we can make it better. Thank you very much.